This program is brought to you by Emory University.
Good afternoon. I'm Sandra Pernetz, and I'm going to continue with the echo features of congenital heart disease in adults. And we're going to focus on the complex cases on this meeting today. I have no disclosures. And the objectives of today's meeting will be Ebstein anomaly, Tetralogy of Fallot, pulmonary atresia intact septum, L-Transposition of the great vessels or congenitally corrected transposition, D-Transposition of the great vessels, and we're going to touch the atrial switch and arterial switch. And at the end, we're going to do tricuspid atresia, Atriopulmonary Fontan circulation. So starting with the Ebstein anomaly, this is a rare congenital heart disease occurring 1 per 200,000 live births. It was first described by Dr. Ebstein in 1866. And it's characterized by an apical displacement of the functional tricuspid annulus and has lack of delamination of the septal and posterior leaflets of the tricuspid valve. And usually the anterior leaflet is fenestrated and tethered. And with this, the right ventricle is atrialized because the tricuspid valve lacked of delamination and joining the annulus of the tricuspid. And there is an annular dilatation, and usually it's associated with PFOs and ASDs. So the normal tricuspid valve is displaced more apically than the mitral valve, and is usually less than 8 millimeters per meter square. It can be mild or severe type of displacement of the tricuspid valve, and multiple echo views is needed to assess the degree of this displacement. And I'm just putting a multi-plane images of this tricuspid. So you'll see in the 4-chamber view, there is this apical displacement. And then this is the 2-chamber view. And this is a short axis at the level of the tricuspid. There are usually association of tricuspid regurgitation is associated with this. PFO, like I mentioned before. Non-compaction LV can be present in this type of conditions, and muscular VSD right in the area where the septal leaflet is inserted. So we're going to start looking at a mild case of Ebstein anomaly where you see that this tricuspid valve is apically displaced compared to the mitral valve, but there's no significant tricuspid regurgitation. There's a little bit of a mitral regurg here seen in blue into the left atrium. And in the 4-chamber view, we can appreciate the displacement again of this septal leaflet. And what we do is we measure the insertion of the leaflet and then compare that to the mitral anterior leaflet. And that should be less than 8 millimeters per meter square. In this other case, which is more severe Ebstein anomaly, you can appreciate that the left ventricle is normal size. However, you see this tissue moving within the right ventricle that represents the anterior leaflet and part of the septal leaflet of the tricuspid valve. If you ever see this kind of a feature, it's usually an Ebstein anomaly. And when you put the color Doppler, you can appreciate here, almost like in that view of the outflow tract towards the pulmonary artery, that the tricuspid valve is very close to the outflow, and this is not a normal anatomy. And there is some regurgitation seen in red here, and this is the outflow. All this part of the right ventricle is atrialized because of the so apically displaced tricuspid valve. In this RV inlet view, where you can appreciate the apical displacement, and you see that the tricuspid valve has not delaminated completely to join the annulus of the valve, stay in the closure more so into the right ventricle. This is the coronary sinus. So all this area here of the right ventricle, it's atrialized. In this three-chamber view, you can appreciate, again, the apical displacement of the leaflets. And this area here is atrial tissue, but it should be part of the right ventricle because the annulus of the tricuspid valve is right at this plane. So the leaflets sometimes can be lack of coaptation, like you see in this case, in this off-axis, short-axis view. And because of that, you have this significant amount of tricuspid regurgitation. And on this other plane, you see that the tricuspid regurg, it has an unusual fashion is because the leaflets are very displaced apically. This is the left ventricle that has a D shape because of the amount of tricuspid regurg. And all this area of the right ventricle is atrialized. This four-chamber view of the severe Ebstein, you can appreciate that the leaflets are almost at the apex of the right ventricle. So the normal annulus is at this plane. So all this area here of the right ventricle is atrialized. So there is barely any right ventricular function left from a normal anatomy of the right ventricle. And on the color, you can see that there is significant amount of tricuspid regurgitation, and it's dilated the right atrium because of this. And sometimes the tricuspid regurgitation is so eccentric that we need to utilize the 3D in order to see 3 planes of that tricuspid regurg and measure the vena contracta right in the at the plane, and the vena contracta will be the same as your effective regurgent orifice. So the associated defects with Ebstein's are non-compaction ventricle, and you can see on this example that the left ventricle at the apex has heavy trabeculations consistent with this non-compacted area. And the same in this two-chamber view where you can see that the left ventricle has this non-compacted apex. But there's also PF4 ASDs, and in this case, in the subcostal view, you can see that there is a PFO with bidirectional flow. There is red left to right, and this blue is right to left. This is the superior vena cava. This is the right atrium. This is the left atrium. And also muscular VSDs, especially in the area where the tricuspid septal leaflet was inserted. This particular case had already tricuspid valve replacement, but you can see this small muscular VSD. And usually this, they have very little shunts because they're very small. So now we're going to move to the next pathology, which is Tetralogy of Fallot. So Tetralogy of Fallot consists of 4 components. One is the ventricular septal defect, and usually there is a deviation of the anterior of the conal septum. And with that, you can see that the aorta overrides the interventricular septum. And because of this, the right ventricular outflow tract gets obstructed, and the significance of obstruction will lead to right ventricular hypertrophy. So these are the 4 components of the Tetralogy of Fallot. So again, this is a left parasternal long axis view where you see this left atrium, the mitral valve, the left ventricle, this VSD, and then the overriding aorta. And this is a very small right ventricle, but this significant hypertrophy. In the short axis view at the level of the aortic valve, a little bit below, you can see, again, very large ventricular septal defect. And this is all right ventricle hypertrophy and leading to an obstruction. So the color flow here demonstrates that there's small outflow tract and the gradients with the Doppler that are significantly high at 91 with a mean of 54. So sometimes the valve can also be abnormal and stenotic, sometimes atretic, but there is a very long area of the infundibulum that is stenosed, and these are what they get repaired during the repair of Tetralogy of Fallot. In the 4-chamber view, I'm focusing on the right side, and you can see that there is a right-sided dilatation as well as very significant right ventricular hypertrophy. And also the tricuspid valve seems to be a little bit thickened. And if we move to the 5-chamber view in this apical views, you can appreciate how the aortic valve overrides the ventricular septum. And in some cases, you have some degree of aortic insufficiency, could be mild or a little bit more. And in most of these cases, the aortic root is dilated because it's the only source of the cardiac output. So you're going to see a lot of the root dilation in these tetralogy cases. And then you can see the very small ventricle, and this is a right to left shunt leading to the aorta. And this is actually a very nice 3D demonstration where you're looking at the right ventricle, and you can see the relation of the ventricular septal defect, the aortic valve overriding that defect, and the very narrow outflow tract to the pulmonary artery. And this is the anatomy of the right ventricle, where you see this is the inlet, and this is the outlet, and the infundibulum is in this area, the right atrium on top. So after these patients are born, usually they get repaired before they come to our adult congenital clinic. And when they come, we're going to find a constellations of sequelae of this palliative repair that they have as an infant. And one that's, like I mentioned before, that could be just residual AI due to the aortic dilation. And in this case, this septal defect was already patched and there's no residual ventricular septal defect. But you're going to encounter that the right ventricle in some of these cases are dilated, and we'll see why. But in this case, your left ventricle function was normal in the short axis, but you can see that there's some D shape in the very large right ventricle, and there's no longer a right ventricular hypertrophy. And that's due to this significant amount of pulmonary insufficiency that's left after the repair. So when they're babies, they open up the stenosis, they remove all that obstruction at the infundibulum, they do an RV outflow tract augmentation, and then they open up the valve, and they don't put a valve in because the baby grow and the valve doesn't grow with the kids. So you have to wait until they get older, and that's when they come to our clinic and present with right ventricular dilation and sometimes arrhythmias and so forth. And this is a Doppler that you're going to see across the outflow tract. It's depending on how much residual stenosis there is. They could be high velocities in systole. But here, this diastolic flow represents the pulmonary insufficiency, and that is very, deceleration time is very sharp. That is considered severe AI. But also noted that there is diastolic forward flow, which is this little Doppler signals here, and that represents flow in diastole out to the outflow tract and is consistent with right ventricle restrictive physiology. These are ventricles that they were very hypertrophied and they're very stiff. And even after you open up the valve, they are still have some damage to the myocardium. The tricuspid valve sometimes can be leaking, and this is because the septal leaflet that is near the VSD can be damaged and compromised during the ventricular septal repair. So it's important that we also address the tricuspid regurg to see if needs to be repaired at the time of the pulmonary valve replacement. And I like to use a lot of the 3-dimensional with color because it gives me a better sense of the degree of the TR, and these jets are very eccentric. So I think it's just is a better evaluation than the PISA method, because these jets are never circular and never, the vena contracta in one plane are different than the others, like you see in this image. Now, the apical four-chamber view, you're going to see that the right ventricles are dilated, and the function can be normal or decreased depending on how the myocardial function is on these ventricles. This one is actually ventricular function is preserved. So the right ventricle is dilated, but we underestimate the volumes due to, we're using only one plane and the four chamber like you see here. But I think it's important now with new softwares that we utilize this volume assessment of the right ventricle. So you have the four chamber and the two chamber, and then this view is where you can see the semilunar shape of the right ventricle over the left. And we can estimate the volumes based on this software. And we get a lot larger volumes than just measuring on the four chamber view. And we are doing this and trying to compare this to the MRI volumes. And of course, this can be used on patients that have better windows. So when the patient comes in and needs a pulmonary valve replaced, this can be a different approach. One is a surgical approach, like you see here. There is a tissue prosthesis in the pulmonary position. You see the struts and the tissue of the valve in the middle, and a very nicely normal functioning pulmonary valve with a little bit trivial PI through the leaflets. And here is a short axis on FASE of this surgical valve, where this is the sewing ring, and you can see the nice three leaflets opening in the little trivial pulmonary insufficiency in the middle. I think this is very important to look at this valve carefully, because these patients can have endocarditis and disruption of the valve. So we like to address this at baseline and continue following the patients, so we can see the difference every time they come to clinic. The other approach is the percutaneous approach. And this is actually now being used more commonly, and save the patient from having another surgery. And you can see that these valves are mounted on a stent frame, so they can be stable. And then inside there is, in this case, a Melody valve. And you can see that there is no perivalvular leaks around the stents, neither through the valves. And we also like to do a little bit more with the 3D to, again, see the leaflets of the valve, the stents, and you can see nicely how thin are these leaflets, and it's opening very nice. The other way of replacing these valves is doing an RV to PA conduit. And the reason why they use conduit is one can be homograft or prosthetic conduits with prosthetic valves in the conduit. And this is what you see here. And this is all the graft material. So they put a graft at the proximal part of the graft is near the RV outflow tract, and the distal is within the main PA. So you want to be sure that the entire conduit is patent when you put your color Doppler. And there is no regurgitation with this. And they use this when there is anomalous coronary associated with this Tetralogy of Fallot, especially a right or a left anomalous coronaries that are near the pulmonary valve, that it can be compromised at the time of a surgery, or when there is severe right ventricular obstruction, or pulmonary atresia where there is not enough room to put a bioprosthetic valves. So when we move now to another condition, the pulmonary atresia intact septum, as the word says, the patient was born without a pulmonary valve, but there is no VSD. So you have to think that these ventricles are under high pressure during, after birth, and these ventricles don't develop normally. So you will encounter in the adults that the left-sided chambers appears to be normal, but there is a very prominent right ventricle here with this flow swirling that is from the pulmonary insufficiency. The more severe type, like you see here, is where there is actually no formation of the right ventricle. All this is hypertrophy from very high pressures. And usually these ventricles have the tricuspid valve is dysplastic or very abnormal. This is the left ventricular outflow tract. This is a pulmonary vein draining into the left atrium, but the mitral and aortic valve seems to be normal. Here's the short axis on a mild case where you see heavy trabeculations, however, in the right ventricle. This ventricle seems to be dilated. There is some D shape of the septum, not significant, and a good function of the left ventricle. But when you go to a more severe case, you see that the right ventricle, it just barely the cavity exists. All this is hypertrophy. And there is, in some scenarios, we'll find what we call sinusoids, which is coronaries still draining into the RV cavity because they never got compacted from the high pressures from the pulmonary atresia. In this RV inlet view, you will see that the tricuspid valve is not completely normal. It's some dysplastic and is actually closing a little bit more towards the ventricle than to the annulus. And you see how there is some heavy trabeculations within the right ventricle, more so than the normal anatomy of the right. So when these patients are repaired, they actually open up the stenosis of the pulmonary atresia, and they leave the patient with significant amount of PI and sometimes PS, like you see in this case. And this is why this particular patient had dilated right ventricle, is because of this severe pulmonary insufficiency. The aorta is here, this is the pulmonary valve, this is the main PA, and this is the right and the left pulmonary arteries. In the four-chamber view, you will appreciate that there is a dilated right atrium, and that's probably due to some degree of tricuspid regurg. But also notice how the dysplastic tricuspid valve and some dilation of the right ventricle and heavy trabeculations. And the left-sided chambers are normal, and there is no septal defect, so it's intact septum. So there, another example here of type of dysplastic tricuspid valve with this mild to moderate degree of TR. And sometimes you can have some gradient across the tricuspid valve, so mild stenosis because of the dysplasia of the valve. And you can see here on the 3D that the tricuspid valve is not normally formed. There's some fusion between the posterior and septal leaflets, and then also between the anterior and posterior commissure as well. So this valve has some, the opening is a little bit decreased. In some more severe cases, you will see that the right ventricle, it's abnormally formed, only an inlet view with an absent apex. All this apex is all hypertraveculated, so it's not functioning. And in the more severe type, is there very any cavity, and the tricuspid valve is almost, sometimes they remove it. And then you see this very large right atrium, but the question is how the ventricle is, how the pulmonary artery is getting the blood flow. So the blood flow will come from the IVC and the SVC entering this big right atrium, and the right atrium then is connected to the pulmonary artery, and that is the Fontan procedure. So you will see that the tricuspid valve has been removed in this case. So you see a to and fro flow, but there is only to the inlet part of the ventricle. There is no outlet because there's severe pulmonary atresia. So this right atrial flow will go directly to the PA, and that's the Fontan, which is the classic Fontan seen in this cartoon here. SVC and IVC coming into the right atrium, and then the appendage is sewn into the PAs. In other cases, they go through the lateral Fontan route. So you see that there is very small right ventricle. And then this structure here behind the right atrium is the lateral tunnel Fontan. And this cartoon can demonstrate how the blood is now being directed to the pulmonary arteries, the inferior vena cava, through the conduit up into the pulmonary arteries. And in some cases, they fenestrate, meaning that they open a little hole in this graft. So there is decompression of the Fontan into the atriums. This blue flow here is a left pulmonary vein. This red is the right lower pulmonary vein. There's a little bit of mitral regurgitation, and this left ventricle that is functioning normal. They also remove the septum, and that's to allow the coronary sinus flow that is coming back into the right atrium to drain back into the left and out to the LV and the aorta. So let's move to another condition, congenitally corrected transposition of the great vessels. So this is characterized by, the incidence is 0.01 to 0.07 per 1,000 live birth. And most common is the SLL nomenclature, which is cytosolitus. That means that the left atrium is on the left, the right atrium is on the right. There is L loop of the ventricles. So that means that the left ventricle is now on the right and the right ventricle is on the left. And there is transposition of the great vessels. There is atrioventricular discordance, meaning that the right atrium is connected now with a left ventricle, and the left ventricle is connected to the PA. The left atrium is discordant with the right ventricle, and then the right ventricle is discordant with the aorta. And that's a ventricular arterial discordance. So we have the two discordants, so two wrongs makes a right. And these patients don't require any kind of surgery at birth, because the blue blood that is coming from the SVC and the IVC goes into the right atrium, into the left ventricle, out to the pulmonary arteries. However, the left ventricle now is a morphologic left, but functioning as a pulmonic ventricle. The pulmonary veins will drain into the left atrium, and that red blood will go into the right ventricle and out to the aorta. However, now the right ventricle is morphologic as a right, but is functioning as a systemic ventricle. This congenitally corrected transposition can have Ebstein anomaly in most of the cases, can also have ventricular septal defect and any other associated lesions. So on the parasternal long axis view, you're going to encounter that there is the posterior ventricle is very heavy trabeculated with a moderated band. And then on top, I put a normal parasternal long axis so you can see the difference of the two. So this left atrium is connected through the tricuspid valve into a right ventricle and out to the aorta. This is the anterior ventricle, which is now the left, functioning as a pulmonic ventricle. When we move to the short axis, you're going to see that there's a normal view on top, so you see the difference. Sorry, I just went back by mistake, I'm so sorry. So you'll see that the posterior ventricle is the right, morphologic right, but it's the systemic ventricle. This is the tricuspid valve, and this is the right ventricle, the left ventricle that it's now anterior. In the short axis at the level of the great vessels, you will encounter that the posterior vessel is the pulmonary artery, and the anterior vessel is the aorta that is to the left of the patient. And that's why it's L-loop ventricles and L-transposition. So these ventricles, when they are born, they live. Nothing needs to be done. The blood is going into the normal, the blue blood goes back to the lungs and the red blood goes to the aorta. And in the 4-chamber view, you have the normal on top of the screen. You will encounter that the right ventricle is to the right of the screen, and the left ventricle is to the left. And you know that this is a right ventricle for several reasons. One is that there is apical displacement of this AV valve, and that is a tricuspid valve. The tricuspid goes always with the ventricle. The AV valve always follow the ventricle. So this is the tricuspid, follows the right. This is the mitral, follows the left. You will see that there is the left atrium that appears to be dilated, most likely because there is some mild Ebstein anomaly of this tricuspid valve, and there is a degree of TR. And then here, the right ventricle function is preserved, and you see a moderated band right here along the mid ventricle. This is the right atrium through the mitral valve into a normally function left ventricle. In this 3-chamber view of the right ventricle, you can appreciate another feature of these morphologic right is that the AV valves don't have continuity with the great vessel, that in this case, the aorta. There is the conal septum here. In a left ventricle, the AV valves will have continuity. So this is anatomically a right ventricle with a lot of heavy trabeculation because it's functioning as a systemic ventricle. And this is the left atrium. So left atrium, tricuspid valve, right ventricle out to the aorta. In this 3-chamber view, you can appreciate the anatomy now of the tricuspid valve. So you know that this is going to be a right ventricle, and there is this mitral valve. This is the left ventricle. This is the septal leaflet. This is the posterior leaflet, and this is the anterior leaflet. And this ventricle leads out to the aorta. And like I mentioned before, Ebstein is the most common associated lesion with this type of congenital heart disease. And then this ventricle, this atrium gets dilated, and this patients will require to have their valve replaced over time. So moving now to those transpositions that require intervention right at birth is the D-Transposition of the great vessels. So you see in this cartoon, and I will explain as I go along, this one is a cyanotic congenital heart defect. The aorta will arise from the right ventricle, and the pulmonary artery arises from the left ventricle. So there is a D loop of the ventricles. So the left is on the left and the right is on the right. There is atrioventricular concordance, but there is ventricular arterial discordance. So this creates a 2 parallel circulation. VSDs may be present in about 50% of the cases. It can be LV alpha tract obstruction in about 25, anomalous coronary in 1/3 of the cases. So if we go along again with the circulation of these babies, the inferior vena cava and superior vena cava will drain into the right atrium. This our blue blood will go into the right ventricle, and that blue blood will go out to the aorta. Then the red blood will come from the pulmonary veins into the left atrium, into the left ventricle, and out to the pulmonary arteries. So these babies after birth require intervention. In this parasternal long axis view, you will see that there is a very D-shaped left ventricle. There is some systolic anterior motion of the mitral valve due to the shape of the left ventricle. And this left ventricle leads the blood to the posterior pulmonary artery. And this anterior right ventricle is very heavy trabeculated because it's now a systemic ventricle that leads the blood to an anterior aorta. If you go up higher on the parasternal long axis view, you will see that there is 2 parallel great vessels, the anterior vessel being the aorta, and the posterior vessel being the pulmonary artery, and the pulmonary artery starts to dive and bifurcate. And in this patient there is mild aortic insufficiency. And on the apical views, you can actually see again the parallel great vessels. Here is the pulmonary artery and anterior aorta coming out of the right ventricle. In the short axis view, you will see that there is a very D-shaped left ventricle due to high pressure in the right because it's a systemic ventricle. And because there is so much hypertrophy, you can appreciate the anatomy of the right. This is the inlet and this is the outlet view. And the left ventricular function was normal. And when you go to the short axis at the level of the great vessels, you will appreciate that the pulmonary valve is posterior and now the aorta is anterior and to the right. And this is what is the D-Transposition of the great vessels. So when the babies are born, they need immediately some intervention to mix the blood, and they have what is called the Raskin procedure. This is done in the cath lab, where they put a catheter through the foramen, they inflate a balloon and just open a big atrial septal defect. And after the baby is grown, then they have another repair, palliative repair. And if the babies were born before the 70s, after the 1958, they could have either these two types of atrial switch. So the Muster procedure done by Dr. Muster was made out of synthetic material. So they are going to reroute the blood from the inferior vena cava and the superior vena cava into the left atrium through mitral valve. Then the blue blood will go into the left ventricle and out to the pulmonary arteries. The same with the pulmonary veins will drain into this synthetic material, and they will drain directly into the right atrium and then into the right ventricle and out to the aorta. The difference with the Muster, the Senning, which is Dr. Senning, is that it's made out of autologous tissue, whereas the old tissue of the atrium, and they create this baffle of the pulmonary veins into the right atrium, out to the tricuspid valve, right ventricle, and to the aorta. And then through an ASD, you can see here, the IVC and SVC blood will come back into the left atrium and now left ventricle and out to the pulmonary artery. And we'll see examples of this. So the pulmonary baffles that you'll see this in this cartoon on top is what this is represent here. You'll see that the pulmonary veins are now being baffled into the right atrium, to the right ventricle, and out to the aorta. The only caveat with this procedure is that the right ventricle is going to continue being the systemic ventricle, but now you have the blood flow is in series and not parallel. And here is a three-dimensional image of this. This looks like a Senning. It looks like the own atrial tissue was created the pulmonary baffles into the right atrium. The systemic venous baffles now, the IVC, which will be in this graft here, will be this synthetic material here, is routed from the right part of the inferior vena cava into the left atrium, and then into the left ventricle and out to the pulmonary artery. And the superior vena cava, which is this on here, as you see in this cartoon, will represent this part of the, in your view here. This is a very high parasternal view in the short axis. So you'll see the blood flowing from the SVC now into the left atrium, and then the inferior vena cava into the left atrium. Looks like a pair of pants. So similar to what you have here in this cartoon. There is a leak in this baffle, is that what you see here in red from the pulmonary baffle behind into the SVC. So there is a left to right shunt. This is the aorta, and that's the pulmonary artery. And because of this baffle leaks, this ventricle's left ventricle, which is the pulmonic ventricle, tends to be dilated, like you see in this picture, different than the one you saw before. And this is because of the sort of like a behaving ASD physiology. This is the right ventricle on top, and the D shape due to the pressure load of the systemic ventricle on top. So in this cases, we need to do bubble studies to evaluate the leaks. So we do it from the left arm to see SVC baffle leaks, which is you see in this view. And I'll let it play again so you can see how the bubbles come in immediately after the injection of the bubbles on the left arm. And then if you're considering a baffle leak from the inferior portion of the baffles, then you do the IV from the foot. And you can see here that this is the IVC baffle into the left atrium. And there is, let it play again, you will see how the bubbles are going to cross over immediately into the pulmonary baffles and out into the right ventricle, which is the systemic. So those baffles can be closed percutaneously, but those are the things that we look as a sequela of this type of procedures. The other problem that we can encounter is pulmonary baffle stenosis. As you can see here, there is a kink, a narrowing of the blood flow coming from the pulmonary veins into the right atrium. And then this is going to have a similar physiology as a mitral stenosis. So we put the Doppler in this area and we measure mean gradients, which in this case is 4. So it's considered at least a moderate stenosis of those baffles. Also, the inferior vena cava or superior vena cava baffles can get narrowed. Like this example, there is a narrowing in between the IVC and the left atrium. And we also run the Doppler to see how much gradient there is. We tend to overestimate the gradients because these are not orifice, but they're long tubes. So, but it gives us an idea how much obstruction there is through the flow. So the other problem that we can encounter is dysfunction of the right ventricle. Over time, these ventricles get insufficient and the function decreases because it's a ventricle that was not made to pump blood to the high pressures towards the aorta. So we have to be carefully assessing this function every time the patient comes to clinic. So we try to add more information than just an apical 4-chamber view. Here you see that there is a triplane image of this right ventricle. So we can see the ventricle in the 4-chamber, in the inlet outlet view or the 3-chamber view, and the 2-chamber view of the same ventricle. Here you can appreciate that there is no continuity between the tricuspid valve and this aorta. This is the conal septum here. So we like to add more information, so we do ventricular strain of these ventricles and we to follow the true systolic function. This particular case was preserved, it's 15, which is not the same case as this one. But we've been doing strain for a long time on these ventricles, and we have a cutoff that if the global strain is 10% in the 4-chamber view, that's a poor prognosis for this type of patients. So if the patient was born after the 1978, then they will have a different type of procedures to repair the D-transposition of the great vessel. And this is done, the first cases was done by Dr. Jatin in 1978, and it's considered now an arterial switch. And what is done is they take the coronaries and they reimplanted now into the pulmonary artery, but the arteries above are switched. So they leave the trunks of the valves, they dissect the vessels above, and then they switch it. So now you'll see that the echoes will look pretty normal. The left ventricle now is going to lead the blood into this neo-aorta, and then the right ventricle is going to lead the blood to the near-pulmonary artery. The caveat with this is that this this vessels can have some insufficiency, and we'll see some examples of that. So this is a short axis view of a patient who was born with D-Transposition but had a Jettine procedure on or an arterial switch. And you see that the ventricle function is normal, the right ventricle looks normal as well. But if you look at the hypersternal views, you will see that the proximal portion of the vessels looks still parallel because they dissect the vessels above where the valves are. So the aortic valve was the native pulmonary valve, but now it's the neo-aorta. And in this particular case, you will encounter a little bit of the aortic insufficiency. The pulmonary valve now, it's the aortic valve is the neo-pulmonary valve, and you will see that it's flowing normal without obstruction. And here in the apical 5-chamber view, you will have the same appreciation where they look parallel. So the arteries have been switched above. So this was at birth, the pulmonary valve, now is the neo-aorta. And this was the aortic valve at birth, now is the neo-pulmonary valve. You see a little bit of pulmonary insufficiency and just a small degree of aortic insufficiency. The left ventricle function is being preserved in this case. So the other maneuver or procedure that they do with this is called the LeCompte Maneuver, where they actually take the posterior pulmonary arteries and they drape it in front of the aorta. So when you're scanning these patients, your short axis of the pulmonary artery are going to look a lot different. And I have an example here of the MRI so you can appreciate how it looks. So it's draped over the aorta, the right pulmonary artery and the left. And this is how the echo will look like. And it's called the LeCompte Maneuver. The only caveat with this is that these branches can get stenosed and compressed sometimes by the aorta or by the surrounding tissue. So we have to be very careful that we address both right and left pulmonary branches. So again, this is a high suprasternal notch or hypersternal views, and we're kind of aiming to the pulmonary arteries. And on the apical 4-chamber, the heart looks completely normal because you have switched your arteries. So your right ventricle is now pumping blood to the lungs, and your left ventricle now is pumping blood to the aorta. However, we can encounter a significant amount of neo-aortic insufficiency after this type of procedure. So we want to carefully assess the new pulmonary and the new aortic valves. The other thing that we are very hard to visualize are the reimplantation of the coronaries because of the way they switch the arteries. So it makes it really hard by echo to assess that other part of the procedure. So we leave that for the CT and MRI. So our last case is going to be the tricuspid atresia. So tricuspid atresia is an incidence of 2 out of 10,000 live births. As the word says, the tricuspid valve is atretic, so it's a plate between the right atrium. There's no valve. There is hypoplastic right ventricle. It's associated with an atrial septal defect. Sometimes the patients can have ventricular septal defects. And in some cases also they could be transposition of the great vessel. In this cartoon, the vessels are normally related. So the palliative repair of this tricuspid atresia are either a classic Fontan, which is similar to the example that I mentioned before, where the IVC and SVC draining into the normal right atrium is now the blood being let out to the PA through the appendage. It's called the Atriopulmonary Fontan. The lateral tunnel Fontan, which is a conduit material directing the flow from the inferior vena cava up into the pulmonary arteries. This can be fenestrated or not. The extracardiac Fontan is a conduit outside of the right atrium, but still leading the blood from the inferior vena cava into the pulmonary arteries. And the other part of the Fontan repair is the Glenn shunt, which is the superior vena cava is now being sewn into the right PA, and it's no longer part of the right atrium. You can also have, if you have two SVCs, there will be two Glenns, the bilateral Glenns. So in this case of the tricuspid atresia and the parasternal long axis view, you will see that there is a left atrium connected to a left ventricle, and their left ventricle seems to be a little bit dilated, but with preserved function, but there is no chamber in the right ventricle here, is because it's very small. There is no flow, no grow. In this inlet view of the right ventricle, you will see that there is absent of this tricuspid valve, is atretic. This is the lateral tunnel Fontan, and there is an atrial septal defect. This is the right atrium, this is the left atrium. And in this particular case, the aorta is anterior and coming out of this very small ventricle. There is a large VSD on that patient. So this patient had a classic Fontan. Is another case where you see the four-chamber view. This is the tricuspid atretic plate. There is a little the little cavity of the right ventricle, maybe because there's a VSD. There is this giant right atrium filled with smoke and possible layers of clot. And there is no atrial septal defect. There is this left atrium connected to the left ventricle. So this was the beginning of the era of the Fontan procedures. There's no longer being done because of this same, consequences is the formation of clot in atrial arrhythmias. So here is an example of a lateral tunnel Fontan where you can see the structure behind the right atrium, that it's, there's a cartoon here where the blood is directed from the IVC to the pulmonary arteries. So the IVC will drain here and then up to the PAs. There's the pulmonary veins draining into the left atrium, to the left ventricle out to the aorta. And then there is an atrial septal defect that is surgically created at the time of the Fontan. This is the right atrium, and the blood that it comes from the coronary sinus will be coming into the left atrium through the ASD. This is another example of the atriopulmonary Fontan where you can see that there is a lot of congestion of the hepatic veins. There is this giant right atrium with this swirling and stasis of the blood because of the atrium is poor functioning. And on the right parasternal views, you can see the connection of the appendage out to the pulmonary artery. And this is this blue flow that you're seeing here on your color Doppler. And this is going to be this area here demonstrated on your cartoon. And this is the pulmonary veins into the left atrium. Notice that there is no atrial septal defect. So the lateral tunnel can have a fenestration like you see here is this continuous flow. And this is to decompress the pressure in the Fontan circulation. So the hepatic veins in the liver don't get that congested because of the very high CVP. So the Fontan circulation is a passive flow. So the CVP have to be higher than your wedge pressure in order to the blood to flow to the lungs. So you see another example here where there is this lateral tunnel. There is this left atrium, your ASD. There is this tricuspid atresia. In this case, there is a large ventricular septal defect. So you'll see that the right ventricle is a little bit larger because of that. And you see the to and fro flow from the VSD and the fenestration right here in the middle. So we measure the velocities and the mean gradients across this fenestration. And this patient had 6 millimeters of mercury. That is telling us that there is a high pressure, high CVP that is being decompressed into the atriums through the fenestration. And here is another example of a lateral tunnel from the subcostal view. You can appreciate that the hepatic veins are dilated. And this is the blue flow coming away from the transducer going into the Fontan and out to the pulmonary arteries. There is no fenestration in this example, but we're looking for any obstruction within the Fontan procedure. This is the left atrium, and that's the left ventricle. And then this is a suprasternal notch. So we're doing is a view of the IVC Fontan flow that it's going up towards the transducer and then out to the pulmonary arteries. This is the ascending aorta, the arch, and descending aorta. But you can see here that there is no obstruction within the flow into the PAs. And you can appreciate that the blood flow in the pulmonary arteries is no longer pulsating, but it's venous flow. And that's because of the Fontan circulation. You can see here red flow coming in from the Fontan and the blue flow going into the left pulmonary artery. This blue flow here is the descending aorta. This is your aortic arch, your neck vessels, descending aorta. So when you sample the pulmonary, left pulmonary artery, you will encounter that there is venous flow and not pulsatile flow. And you have the flow augments with inspiration and decreases with expiration. And then the Glenn shunt can be evaluated when you do a suprasternal notch near your IJ, the right IJ down to the subclavian pointing down. And then you'll see this blue flow that it's coming from your SVC now directed into your right pulmonary artery, like is demonstrated here in this cartoon. Your SVC flow, that is this blue flow, and then your right PA is this blue flow here. This other red flow, it's from the Fontan circulation. This is a three-dimensional view of the Fontan coming from the IVC into the PAs, and from this is the nominate vein, and then joining this superior vena cava on the right and down into the pulmonary artery. This is another example of a Glenn shunt where you see this blue flow of the SVC connected to the pulmonary artery. And when you sample, this flow is more continuous difference. This is a normal example of an SVC. So you can see that there is an S and a D wave and an atrial wave back here, but you don't no longer have that because your SVC is now connected directly to the pulmonary artery and not to your right atrium. So these are the type of flows and functions that we assess with the tricuspid atresia. And when they come to the adult world, they're already been fixed. So this is all the parameters that we use. And there are a little bit more, but for the talk, we just going to leave it to here. So thank you much for your attention. And I hope it was not overwhelming, but I want to welcome all you guys, fellows who are coming and rotating with us to sit with us and learn a little bit more about echo and this congenital cases. Thank you very much for your attention.
The preceding program is copyrighted by Emory University.